election results. I give the opportunity to Dr. Aditya, our treasurer, to introduce our today's guest speaker. He is a very fast friend of Aditya.
Yes.
Aditya, over to you.
Good evening, everyone. Good evening, HOD sir. Good evening, Karne sir. And good evening, Kanse ma'am. And all other participants in this lecture. Myself, Dr. Aditya, I'm treasurer of Karad ISA. Today, I'm going to introduce you to our guest speaker. He's a very good friend of mine. He was a junior to me in KIMS anesthesia department. He has done MD in KIMS anesthesia. After MD anesthesia, he has done a postdoctoral fellowship in regional anesthesia and acute pain management in Care Hospitals, Hyderabad. Tushar, please guide me if I go wrong somewhere.
Yeah, no problem.
Yeah. After that, he has done a certified interventional pain sonologist certificate course in USA. And also he has done a certificate course in team sports physician, Barcelona, Spain. Also, he holds a diploma in MSK ultrasound. And he has also done a certificate course in essentials of palliative care. So a lot of degrees there, Tushar. You have, and he's a very informally. Let me introduce him to all the participants. He's a very humble person. He's a very good anesthetist. He was my junior all the way in KIMS anesthesia. He's very well known to many people over here, and this is my actually pleasure to introduce you to him to you people. So over to you, Tushar. Let's start with the lecture.
Shares. Can I share my screen?
Yeah.
So now is my screen visible?
Yes.
Yeah. Just a minute. Am I audible?
Yes.
Yeah. So a very good evening to all, and thank you, Aditya sir, for a nice introduction. And firstly, it's such an honor and privilege to be invited to this webinar. And it's wonderful to see all my teachers, seniors, and friends who have actually played a crucial role in starting my career in pain medicine. And my first exposure to pain medicine was, of course, in KIMS Karad, where Dulquer sir used to perform sympathetic blocks for peripheral vascular diseases. So probably that experience sparked my interest in pain medicine. And so I'm deeply honored to have sir moderating this webinar session. And I thank him and all my mentors for their guidance. I also want to extend my gratitude to ISA Karad branch and Society of Anesthesiologists of Maharashtra State for organizing this event and inviting me to share my experiences in the field of pain management, as Jaivan sir was, giving introduction to chronic pain. So it holds a very crucial importance in healthcare society. So again, so as anesthetists, we are all aware of the vital signs, heart rate, blood pressure, temperature, respiratory rate. But most of the times, we forget the fifth vital sign, which is pain. And probably because pain is perceived to be less serious than cardiovascular diseases, diabetes, and rather we perceive pain as consequence of aging or condition, and often uh, pain sufferers are they're asked to live with it most of the times, which is not good. So with the advances we have now in pain, so pain can definitely be managed. And chronic pain is the most common chronic impairment. And one of the survey in India says that 23% of the population suffered from chronic pain. So which is quite high. And pain is not unidimensional, it is multifaceted. So what is multifaceted? it means that it can it affects their body, their mind, the spirit. So it leads to poor quality of life, decreased productivity, psychological distress, physical disability, and this is continued to be expected to rise with an increasingly uh, obesity and sedentary lifestyle. So, as the field of medicine learns more about the complexities of pain, it is important to have a specialized person who can deal with this chronic pain. So, this is the role of pain management. So, like any other healthcare clinician, we do the clinical evaluation and diagnosis of the complex pain, management of pain, and so that can be either conservatively or with the interventions. And most of the interventions we do is image guided. So this is very important. We do either CM guided, CT guided, or ultrasound guided interventions. And the main aim is to relieve, reduce, or manage the pain. Most importantly, improve the quality of life. So just one slide about like how to establish, a career in pain medicine. Uh, so there are some options you can explore, and this is the QR code you can scan for more details. But pain medicine is now considered as super specialty in India. So we have a DM in pain medicine. It started a couple of years back, and there's also FNB in pain medicine, which is a 2-year course, and then there is FIAPM, which is run by the Indian Society for Studies of Pain. And of course, there are university affiliated fellowships, even Maharashtra State has their own pain medicine fellowship. Uh, the private universities have their own fellowships. And uh, for people who don't want to practice complete pain medicine, they just want to explore a few basic things. A lot of short courses and workshops are available. So, what are the types of uh, pain which a pain specialist deals with? So, they fall into three main categories. One is acute pain. So, acute pain is mostly sciatica or acute exacerbations of painful conditions like knee osteoarthritis or rheumatoid arthritis. So, pain specialists deal with these things also. And then there is chronic pain, which can be further categorized into neuropathic pain, for example, diabetic neuropathy or post-herpetic neuralgia or nerve compression syndromes, which includes carpal tunnel syndrome or any other nerve entrapments. And then we have chronic cancer pain, musculoskeletal pain. So MSK pain is basically knee, hip, shoulder, low back, neck pain. So all these come into the musculoskeletal pain. We also do treat low-grade sports injuries like ligament and tendon injuries. So we'll see the cases also in the next few slides. But before that, so what is chronic pain? So it is a complex condition where pain persists beyond the recovery period, and it occurs along with the chronic health conditions. It may occur with the chronic health conditions. So in chronic pain syndromes, to this left, you can see, the pain can be conceived as a disease. So chronic widespread pain. So this, it's basically fibromyalgia. Then we have CRPS, primary headaches and orofacial pain, chronic visceral pain, and chronic primary musculoskeletal pain, which includes your knee osteoarthritis or shoulder osteoarthritis, low back pain, joint pains. So all this come into the MSK pain. And then we have secondly here is basically chronic cancer related pain and post-surgical pain, chronic neuropathic pain, uh, chronic secondary musculoskeletal pain. So all this come into the secondary pains. So the differential diagnosis between the primary and secondary pain conditions may sometimes be challenging. So you can see these arrows. So basically these are the differential diagnosis. But anyways, the patient needs a special care when there is moderate to severe pain. So to manage these chronic pain effectively, we need to know a little bit of basics on pain pathways and pathophysiology of pain. So I'll just cover in a very short a few slides. So this involves the pain pathway involves basically four physiologic processes, that is transduction, transmission, modulation, perception. They go hand in hand. So we'll just see those. So what is transduction? Transduction is basically a transformation of one energy into another. So here it refers to a process by which noxious stimuli, that means painful stimuli, it can be a mechanical or thermal or chemical, and these are transformed into the electrical signals. And this is accomplished through a variety of receptors, which are nociceptors, and these are the nothing but they come from the free endings of A delta and C fibers. So any injury to to cells, they result in the chemical release. So you can see this prostaglandin, serotonin, histamine. See, these are all the inflammatory mediators. And so once these are stimulated, they activate the mechanically gated sodium channels or voltage gated sodium channels, and these depolarizes the nerve. And so once there is transduction, once there is conversion of energy, once there is depolarization, then comes your next step is transmission. So basically, we have A delta and C pain fibers, which fiber, they enter in the dorsal horn of the spinal cord. In the we call this as rexed lamina. So they synapse here with the second order neurons in the dorsal horn, and action potential which is generated is conducted across the peripheral process to the central process, where it depolarizes the presynaptic terminal. So here the neurotransmitters from first order neuron to second order neuron, certain chemical neurotransmitters are released. So this can be glutamate or substance P, which are the main neurotransmitters for sensation of the pain. So their job is to carry the chemical signals from one neuron to another. So once there is depolarization and it is transmitted, so the nerve fibers decussate here, they cross over here and go into the spinothalamic tract, right? So the A delta fibers basically they terminate on the ventral posterolateral nuclei of thalamus. And if you see in contrast to the A delta fiber, the C fibers, they actually terminate into the reticular fibers. So reticular formation is nothing but the it keeps patient awake and alert. So suppose if you're pinching someone, so that is where the the reticular formation is activated. So if you see the patient with chronic pain, they might not be able to sleep properly. So that is because of the a continuous stimulation of the reticular formation. And some fibers terminate into the periaqueductal gray. So this is the main pathway for the descend, which activates the descending pathway. We'll see that some of the fibers, they go on to the hypothalamus and then to the thalamus. So then they end up in the sensory motor cortex. Okay. So after one perceives the pain, either our body can facilitate or inhibit the pain. So there comes a certain important mechanism of the pain inhibition, that is through the central modulation or peripheral modulation. So these are the areas again, various areas of the brain. They feed the periaqueductal gray, which is a very important, which coordinates the body's own analgesic system. And this is a primary, area for the controlling the descending pain modulation. And this periaqueductal gray, they send signal to the reticular formation and also activate the descending pathways through the rostral ventral medulla. So if you see this, a zoomed in picture here. So this is the descending neuron coming in, right? So here one more chemical neurotransmitter is released from RVM. So that is the serotonin and noradrenaline. Okay. So these are the two chemicals which are released here. And what the serotonin will do is basically it will bind to the receptors here on the presynaptic membrane, and they will inhibit the release of substance P. So now substance P is, again, which helps to transmit the pain from first order neuron to second order neuron. So that is basically inhibited. And the secondly, it stimulates the interneuron, which in turn releases the enkephalins or uh, endogenous opioids, basically. So they again stop the release of the substance P. And secondly, they also, block the neurotransmitters from here going to the postsynaptic receptors. So also this is where your serotonin and SSRIs and SNRIs, they act in pain modulation. So most of the chronic patients, you might be seeing that we are giving them duloxetine, fluoxetine, gabapentin. So all this blocks these receptors. So there's another way how the pain can be modulated. So not all signals of the physical pain can actually make it to our brains, and we have some power over it. So that is nothing but the gate control theory of pain, right? So the pain signals are generated when you experience something harmful, like there is a cut or burn, and the pain signals are sent through the nerves to the spinal cord and to the brain. So spinal cord acts like a gatekeeper here, and it can allow the pain signals to pass through the brain or block them. So signals from the other nerves, like those from the touch and pressure, these mainly influence the gate. So that is why whenever we get injury, so we try to rub the area, and that is where, like because the A beta fibers are very the larger diameter fibers, so their signals are sent in a faster way, and then you don't appreciate or perceive the pain as such. And that is also the mechanism for acupuncture or TENS, is like transcutaneous electrical nerve stimulation. So this is the mechanism, gate modulation, gate control theory of pain. So coming to the pathophysiology, so this is also very important. It involves peripheral mechanisms and central mechanisms. So this we discussed. Once there is tissue damage or injury, a lot of chemical mediators are released. So this is one of the peripheral sensitization is one of the key factors in development of the maintenance of chronic pain. So whenever again where a lot of chemical mediators are released, these chemical contribute to inflammation, and also these mediators lower the overall threshold uh, uh, for the nociceptor activation. So meaning that even a small stimulus that wouldn't normally cause pain can now trigger a pain response. So this heightened sensitivity is called as the uh, peripheral sensitization. So because the nociceptors or the pain receptors are more easily activated and they're more sensitive, they continue to send the pain signals to the spinal cord and to the brain even after the initial injury has healed, leading to the persistent pain. There's another mechanism which we call it as sympathetic sensory coupling. So this is nothing but the abnormal contact which develops between the sympathetic nervous system and sensory nervous system following a peripheral nerve injury. So in this picture, sorry. So in this picture, you can see, the sympathetic nerve usually ends in the dermis around the blood vessels. And when there is nerve injury, what happens is the sympathetic nerves, they sprout into the epidermis along with the A beta, A delta, and C fibers. So that is the reason you get all this, sympathetic signs, the vasomotor changes, color changes, increase sweating and swelling associated. So that is because of the activation of the sympathetic nerves. So that is why when we do the sympathetic blocks, the pain is relieved. So that is the one of the mechanism of action for relieving of the sympathetic pain. Another central mechanism is, through the, suppose consider someone had a surgery on their knee, so knee replacement surgery, and post surgery patient didn't have, he didn't experience significant pain relief. And months later, even though the knee has healed well, they might still experience pain during the activities like climbing stairs or kneeling. So this continuous or persistent pain which stays even after the healing period has occurred. So this is called as the central sensitization. And what happens here is the repeated pain signals during or after the surgery has created a pain memory in the brain. Okay, so the brain and the spinal cord, they become conditioned to respond to only to any activities involving knee as a painful, even though the injury has healed. And this persistent pain signals from an injury or inflammation keep coming to the spinal cord and brain, and so they adapt to the constant pain signals, making these pathways carry these signals stronger and more efficient. So this adaptation makes the nervous system better in sending the pain signals, even if the initial cause of the pain is gone. Okay, so and even there is glial cell activation. These are nothing but the support cells of the brain and spinal cord. So they release a lot of inflammatory mediators, and again they continuously stimulate the neurons which continuously fire and they cause the chronic pain. So that was about the pathophysiology of mechanism how the pain occurs, chronic pain occurs. And coming to the assessment and diagnosis of pain, pain assessment is very, very important, and it's a very crucial step. So, if the pain management has to be effective, we should be thoroughly doing the clinical assessment. That is very important. So this is again a normal, on the pain history. This is the mnemonic for it. Onset. So what does a, what makes the pain worse or what makes the pain better? So this, I mean, the quality of pain, whether the pain is, continuous, dull, aching, if there is shock-like sensation or burning sensation, tingling, numbness, paresthesia. So usually that points towards the neuropathic pain. So we have to differentiate between the nociceptive pain and neuropathic pain. And then we see if the pain radiates, where does the pain radiate? So is the nerve affected, or is it the visceral pain, or is it the nociceptive pain? And then comes the severity. Severity is also very important, and it is, so we'll see about that in the next slide. And the time of the day, like, is the pain continuous, intermittent, what time of the day the pain is more. So this can help us to time the medications accordingly. Okay. And also, pain is not unidimensional, as we discussed. It can affect quality of life, psychological problems, distress, and usually it affects spiritual effects also. So all this has to be taken into consideration, and a thorough history is, mandatory to look for or find the pain generators. So this is how you do pain assessment. So these are the unidimensional tools. So basically, unidimensional is, again, you ask the patient uh, to rate their pain, because pain is a very subjective phenomenon. So one person's pain, which is 4 out of 10, for another person's, they might, it might be another person's 10 out of 10 for that person. So it is very subjective. So unidimensional tool includes the verbal rating scale, numerical rating scale is what we commonly follow. So we ask the patient, out of 10, how much pain do you have? So this is NRS, and then we have multidimensional tools. So this is a McGill pain questionnaire. So as I told you, pain is multifaceted. We have to take care of the cognitive, signs and other like the behavioral patterns, the sleep. So everything has to be considered. So this is a detailed questionnaire. So this is most probably preferred. And then we have different tools to assess the neuropathic pain. And then, of course, we do the clinical examination. And as anesthetists, we are not trained to do it. But so when you choose, pain medicine as your career, you have to be thorough in taking doing the general physical examination, musculoskeletal examination. So depending on which area is involved, knee, shoulder, hip. So you need to do some tests for that. You need to do proper examination, neurological examination in case of neuropathic pain or low back pain and neck pain, sciaticas. And depending on, like where the pain is, like the visceral, or so you need to assess the other symptoms as well. And investigations, as usual, that also depends on what is the, diagnosis, what is your clinical diagnosis. So you need to get your X-rays, CT, MRI, depending on the uh, what source you are trying to identify the pain generator. So coming to the management, so we follow the modified WHO analgesic ladder. So this is modified because there is step 4, which is an interventional treatment. When there is acute pain, we actually start from, the step 4, we do blocks and all those things, and then we come down to the step 1. Whereas in chronic pain, we start from the basic painkillers, which includes the NSAIDs and paracetamol. And then we have something called as adjuvant drugs. So these can be antidepressants, anticonvulsants like gabapentin, pregabalin. So all this comes into adjuvant drugs, and this can be done, added into any of these steps. So the second step involves the weak opioids like tramadol and codeine, which is available in India. And the third step involves strong opioids, morphine and fentanyl. And of course, the step 4 is interventional treatment, is mostly what we do. So what happens is, when we see patients, most of the times, till the patient reaches the pain physician, they have already exhausted all these 3 steps, and we are left with the, mostly doing with the interventions. So we'll just see the what interventions we do in chronic pain management. So one of the, steroid injections have been used for ages to reduce inflammation and provide pain relief in conditions such as arthritis, bursitis, tendinitis, or frozen shoulder, low back pain, or we can say sciatica. So these are the common indications for steroid injections. But however, there are a lot of limitations to use steroid due to the side effects and short-term pain relief. So steroids basically they mask the pain without addressing the underlying cause, right? So thus they serve just as symptom management. So more in my practice, most of the times I use steroid for only selected indications. Now what we are using is the regenerative therapy, which unlike the steroids, they aim to repair the underlying tissue, issue rather than just masking the pain. So, one such regenerative therapy option is BMAC. So ideally, we don't call it as stem cell therapy, as this BMAC contains a mixture of stem cells, progenitor cells, platelets, growth factors. So this we use in mostly in the osteoarthritis, tendon injuries, and you must have seen this using orthopedic surgeons using in the hip AVN after the decompression. So we take the bone marrow aspirate concentrate from the anterior superior iliac spine or posterior superior iliac spine, and then we centrifuge this collected bone marrow, and what we get is the progenitor cells, hematopoietic stem cell and mesenchymal stem cells, along with platelets and growth factors. So these we injected into the affected area. And then we have platelet-rich plasma therapy, which uses again the patient's own concentrated platelets. So again, we collect around 20 to 40 ml of blood. We do centrifuge, and we see the RBCs, WBCs, plasma, and platelets, which is Buffy coat, is separated. And again, we take that PRP and inject into the injured tendons and ligaments, probably all muscle tears. And even there is a good evidence of PRP into the knee osteoarthritic conditions. There's another regenerative therapy called as dextrose Pro 3, which has also been used since ages. So it just involves injecting dextrose, maybe around 10 to 25%, into the affected area to stimulate the body's response. So again, we use this, patients who are not very affordable. So we do multiple sessions of prolotherapy into the joints or ligaments and tendons, which strengthen them. And we also do something called as hydrodissection of the nerve, and this is done for the nerve entrapments like carpal tunnel syndrome, neuralgia parasitica, and other nerve entrapments. So this involves just injection of the fluid around the nerve. This creates a separation, and the pressure on the nerve is relieved, and there is improvement in the blood supply to the nerve. And also we use actually 5% dextrose here. So this dextrose also blocks the TRPV receptors, and that also indirectly relieves the pain, improving the function and nerve function and the mobility also. This is another modality of interventional pain where we do radiofrequency ablation. So this is not an when regenerative therapy is not an option, I opt for this modality. So it is specifically used when the disease progression is in advanced stage, like in advanced osteoarthritis or advanced facet joint arthritis, and even certain cancer pain or neuropathic pain. We do radiofrequency ablation. So it involves the heat generation, which is by the radio waves, and they destroy the nerve fibers, and that's why they provide a little long-term pain relief compared to the conventionally used steroid injections. And this RF is done purely for the sensory nerve fibers only, because we don't want to destroy the motor nerve and affect the function of it. So there's another another modality which is called as neuromodulation or spinal cord stimulator. So this is nothing but a pain pacemaker. So we call it as pain pacemaker. So it involves implanting a small device or a catheter, which delivers so basically this is in the epidural space here, what we can see. So this delivers the electrical pulses to the spinal cord, and these pulses, they are delivered through these electrodes, right? And they interfere with the pain signal transmitting to the brain by altering the nerve activity here in the spinal cord. So this masks the pain signals, providing relief for chronic refractory pain conditions. So ideal indications for these are patients who have had back surgery or any other surgery and they didn't have any pain relief. So we do use spinal cord stimulator, or even in cases of complex regional pain syndrome (CRPS), we do spinal cord stimulators. And then we have neuroplasty, vertebroplasty, as well as intrathecal pump, which are again the advanced minimally invasive interventions. So we'll just look at some cases, interesting cases, and then so basically we treat, pain physicians treat any kind of chronic pain from head to toe, right? So that includes migraine. So there are a lot of different type of headaches, which can be either chronic migraine, occipital neuralgia, cluster headache, postural puncture headache. So all these are managed, can be managed with the interventions when the conservative treatment fails. So we do usually botulinum toxin injection, greater occipital nerve, and spinopelvic ganglion interventions for these kind of patients with chronic headache, chronic refractory headache. So this was a case of chronic migraine and also medication overuse headache. And so we did her, a few sessions of Botox injections, which reduced her intensity and frequency of the migraine, so that helps to improve the quality of life to the patients. And then there is another, procedure where we do for chronic migraine or even occipital neuralgia, is the greater occipital nerve block. So as you can see, this is the basically greater occipital nerve lies between the two muscles here, obliquus capitis inferior and semispinalis capitis. So we put a RF needle here. So this is an RF machine here, you can see, and we put a RF needle here. And since this also carries certain motor fibers, we don't do conventional RF here. We do something called as pulsed radiofrequency ablation. We give electrical signals in pulses, so that the nerve is not damaged here. So there are different mechanisms how this works, but mainly it modulates the excitability of the second order neurons. And because most of these headache and facial pain, they are carried by the trigeminal nerve, which again is located in the nucleus of the trigeminal here, spinal nucleus spinalis here. And even if you see the greater occipital nerve, actually, they end up in this nucleus itself. So that's how blocking this great occipital nerve can give good relief to the headaches or migraines. So we do treat neck pain as well. One of the most common causes, the facet arthropathy. So facet is nothing but the cervical vertebral bodies join here, and here basically, and that is basically the facet joint. So it is also a synovial joint, which can wear and tear, and further because of age and a lot of other reasons. So this procedure, what we do is here cervical medial branch block or radiofrequency ablation. So what we are doing is we block the nerves which supply the facet joints here. So that is why the pain is not transmitted to the brain, and patient has good relief. So this is another case of C1, C2 joint osteoarthritis. Here you can see, the patient didn't have any relief with the conservative treatment. So we did the C1, C2 X-ray guided C1, C2 joint injection. And we have to use the X-ray imaging techniques, because as you can see, this is the C1, C2 space, and very close to it is the vertebral artery, which is running here. And on the medial side, you have the spinal cord here. So you have to be very careful while doing these procedures, and that is why imaging is recommended. So again, this is also a very common cause of the neck pain, especially in people who are doing desk job, the IT persons, IT people. So chronic neck pain, myofascial pain, which is not going with the conservative treatment. So we do something called as dry needling, or sometimes we do add local anesthesia to it, and interfacial plane block also. So a lot of nerves run into this fascia. So we do facial injection to relieve or relax those nerves here. So this is a case of C5, C6 disc prolapse, and if you can see, this is not a very big disc bulge, and the patient had radiating pain to one side, I think right side, yeah. So surgery is usually not advisable in these cases because the disc bulge is very minimal. In that cases, we do cervical epidural injection. So this is again also done through the help of fluoroscopy. So we pass the needle through the uh, you know uh, so this is basically the ventral interlaminar line, we call it as, and you can see the dye spread here. So usually, if the patient is having right-sided pain, we specifically target the right-sided here as well. So again, it is usually done at C6 level, C6, C7 or C7 T1 T1 level, because as you go above, there is a very less space between the dura mater. So we don't want to puncture the dura. So that's why we do most of the cervical epidurals at C6, C7 or C7 T1 space. So so basically, what is happening here is it is compressing on this spinal cord here, and one of the nerve roots here, so this is C5 and C6, C6 and C7. So we try to basically give corticosteroid here, and so that relieves the inflammation and also washes out the chemical or inflammatory mediators which are around the nerve because of the discompression. So another common, or I can say as the most excruciating pain known to humanity is the trigeminal neuralgia or suicide disease. The patient has a horrible pain. You know Patients who have suffered from trigeminal neuralgia. So here we do a trigeminal radiofrequency ablation or botulinum toxin in cases where trigemin or the foramen OL where we do the intervention is not accessible. So this is a case of trigeminal neuralgia. You can see the patient screaming. So this is acute exacerbation, and we did RF ablation to this procedure. This is the RF ablation. So we enter through the foramen oval. So this is the foramen oval here. You can see the round structure, small structure here. And depending on which area the pain is, maxillary, ophthalmic division, maxillary division, or mandibular division. So we target those specific areas. So you can see this is the ganglion here. And once the RF electrode is placed, and then we do the RF ablation. So we increase the temperature, so that ablates the ganglion here. And we confirm with the AP view and the lateral view here as well. So this is the end point of the needle here. And post procedure, immediately the patient has immediate pain relief, and there is going to be slight numbness because of the local anesthetic what we have used here. And patients who present with the atypical facial pain, or even the patient with the post-dural puncture headache, so we usually place the nasal cannula, or we do the nasal catheter and we inject local anesthetic to it. So that is basically blocking the spinopalatine ganglion block. And we do another approach. We go through the pterygopalatine fossa here, where the spinopalatine ganglion is located, and we do ablation in cases of refractory post-dural puncture headache or cluster headaches, or atypical facial pain. Also, we do this spinopalatine ganglion block. So spinopalatine ganglion is thought to work through blocking the parasympathetic flow to the cerebral vasculature, allowing the cerebral blood vessels to return to normal diameter. So that's how it relieves the headache. So we do treat a lot of shoulder pathologies also: frozen shoulder, partial cuff tears, bursitis, shoulder joint arthritis. We do a lot of this hydrodistension for frozen shoulder, PRP injections, and radiofrequency ablation for again the osteoarthritis. So this is a patient with frozen shoulder. As you can see, is external rotation is limited. It cannot go beyond 45 degrees, as you can see. And we do something called as rotator cuff interval injection. So just injecting between the coracohumeral ligament, which is thickened in frozen shoulder. And once after giving injection, immediately we do stretching. So because because we have given local anesthesia here, so that will relieve his pain as well. And we do immediate stretching, and the movement immediately increases up to about probably in this patient is almost 70-80% of the movement is immediately recovered with this procedure called as rotator cuff interval injection or hydrodistension. Then, so this is a case of supraspinatus tear. So here you can see we do take help of ultrasound to diagnose these conditions, and you can see a dark area here. So basically, this is a tear in the supraspinatus tendon, and we are injecting platelet-rich plasma here because there is a tear. We want healing to happen, and so we are injecting. We are piercing the tendon here to create an acute injury. So the platelets, they are taken up quickly, and the healing process starts. And here we are again injecting the PRP into the bursa. So bursa is nothing but the space between the deltoid here and supraspinatus. So that gives slowly helps in the healing of the tendon. So that is the regenerative therapy or PRP therapy. And this is a case of advanced arthritis. So as you can see, at the age of probably this was a 81-year-old patient. So it's not ideal to do any replacement surgery as at that age. So we proceeded to do the RF ablation of the articular branches. That means the sensory branches which supply to the glenohumeral joint. So we again confirm with the X-rays as well, and there is a good and long term pain relief to this procedure, where patient is left with no other option. Upper extremity pains, basically the nerve entrapments, carpal tunnel syndrome or radial tunnel syndrome, wrist joint tendon pathologies, decurrence tendinitis. So all this can also be treated. So this is a case of carpal tunnel syndrome here, refractory carpal tunnel syndrome with uncontrolled diabetics. So HbA1c around 15. There's no relief with any other medications. So we can see with the help of ultrasound, as there is compression of the median nerve here in the carpal tunnel, and distally you can see the swelling or thickening of the nerve here. Okay, and we also do the measurement of the nerve here, which is around 19. So it is quite quite thickened here. The normal diameter is around 8 to 10 mm actually. So this is how we do the hydrodissection. So we inject 5% dextrose around the nerve here, so above and below the nerve. So that relieves the pressure on the nerve, and this is in the long axis. So this is the nerve here. As you can see, this is the nerve, and just above the nerve, you can see the facial, just below the tunnel, we are injecting the dextrose. So hydrodissection, again, like I told you, it improves the blood supply to the nerve and helps in the mobilizing the nerve, and also it blocks the TRPV receptors, which again gives good pain relief. So in moderate cases, we need to actually repeat these few sessions actually. So maybe one session might not be enough, and few sessions might be needed to give complete pain relief. So nowadays we don't use much corticosteroids for the carpal tunnel because it gives only very temporary pain relief. So this is a case of tennis elbow. So we are injecting, again, we are fenestrating the tendon, creating an acute injury. And once we create an acute injury, then we give the PRP into the extensor tendon here. So that is what is affected in the tennis elbow. So also when it comes to trunk and abdomen, most common conditions are the post-herpetic neuralgia, chest pain, anterolateral chest pain or abdominal pain, where post-herpetic neuralgia is very common. So this was the at the T5, T6, T7 dermatome. So we did a cryoneurolysis. So this involves ice ball formation around the around the needle, and that actually creates a cryo lesion here, and that blocks the pain signal. So basically this creates grade 2 nerve injury. Okay, so that is how the pain relief occurs, and this is a little safer than conventional RF ablation because there is no permanent damage to the nerves here. And we also do a lot of interventions for chronic pancreatitis or CA pancreas. So we do again the splanchnic nerve block. So this is a procedure where anesthetic, and sometimes we combine steroid or alcohol is injected near the splanchnic nerve. So you can see these are the greater, lesser, and least splanchnic nerves on either side of the vertebral bodies, and together they form the celiac plexus, and they are responsible for transmitting the pain signals from the abdominal organs such as stomach, pancreas, liver, intestine. So any pathologies of the upper abdomen, so we can do this splanchnic nerve neurolysis or RF ablation, or even we can do celiac plexus ablation. But what happens most of the times in cancer patients, there is the anatomy is distorted, or the tumor might be encroaching the celiac plexus as well. So patient might not have significant pain relief, or you might have sometimes missed the plexus. So that is why ideally we do splanchnic nerve, because the anatomy is always preserved at this particular area, because it is quite in near the spine here. So coming to the pelvic pain, so we have pelvic cancer pain, or even atypical pelvic pain, where there is we don't find any reason. Sometimes we have pudendal neuralgia, genitofemoral neuralgia. So all these things can be we do interventions for that. For pelvic cancer pain, we mostly do superior hypogastric plexus block. So as you can see, this superior hypogastric plexus, it lies retroperitoneally, and it is in front of the L5S1 vertebra here, and it provides innervation to all the pelvic viscera. Okay? So it is a part of the abdominopelvic sympathetic nervous system, and so any intervention will give a pain relief to the patient suffering from the pelvic cancer pain. And even there is something called as ganglion impar, or this is also sympathetic ganglion. You can see here at in front of the coccyx. So patients with the CA rectum or perianal pain, so we do interventions of ganglion impar. So you can see the dye spread along the ganglion impar here, and you can see the dye spread here. This is the L5 vertebral body, and this is the sacrum. So just adjacent to the L5S1, you can see the dye spread here. So which is where the superior hypogastric plexus is there. So usually in the plexus here, since it is a plexus, we cannot do RF ablation, because obviously there's not going to be lesioning of all the bigger plexus here. So in these cases, we do alcohol neurolysis. So coming to low back pain, so there are a lot of pain conditions which can cause low back pain. So these are the 5 different cases here. The first case was disc bulge here. So as you can see, this is a L5S1. So this was impinging onto the S1 nerve root here. So this is the S1 nerve root here, small black dot you can see in the right side clearly. Whereas on the left side, there is a disc bulge which is impinging onto the S1 nerve root. So we did a selective S1 nerve root block here. So this is the sacrum again here, and this is S1 foramina here. So we did a out of plane nerve injection, and then we do a hybrid technique for this. So once we put the needle inside the foramen, we use the fluoroscopy, and we give the contrast, and we check. This is the S1, foramen, and this is the epidural spread here. So this along the S1 nerve root. So usually the patient has very good pain relief immediately. So this was one of the cause of the low back pain, which was radiating to the legs. So this patient again, with low back pain, so she already underwent surgeries before. You can see the implants here, and in this patient, the pain generator identification was very important, because she didn't have pain relief with any other injections like epidural injections and all. So even the MRI showed, so this is the facet joints here. So you can see a hyperintense signal here, which shows fluid in the facet joints. So this is the basically the old spinal implant here, and we injected into the facet joint again. So this is a facet joint of L4 and L5 vertebral body here. So this joint, and we collected around 1 or 2 ml of the fluid from that, and we injected corticosteroids into the facet joint, which gave immediate pain relief. Another very neglected cause of low back pain is the discogenic pain coming from the disc. So this is a very new concept now. So as you can see, this is the hyperintense signal here. So there is a tear in the annular fiber. So this is the green thing is the annulus fibrosus. So whenever there is a tear, the nucleus pulposus, which is the central jelly part that leaks out, and that sensitizes the nerves here. Okay, so that causes severe low back pain, and which is, patient is not able to sit for more than 10-15 minutes at one place. So most of the times it is relieved, pain is relieved conservatively. But when the pain is not relieved, even after 1 or 2 months of treatment, so then we do something called as disc biaculoplasty, where we insert the RF needles from both the sides and create a bipolar lesion here, a bigger lesion. So basically here we are in the posterior space here, annulus, and we are ablating the nerves here. So these are the sinovertebral nerves. So we are ablating the nerves here. And again, this is a case of persistent post-surgery pain. So with again low back pain, and so we did a caudal epidural, and we saw the dye spread here. And as you can see on the right side, there is no dye spread at all. So this usually confirms the epidural fibrosis, which also causes the low back pain, and it also impinges on the nerves L5S1, so causing the radicular pain as well. So we inserted a catheter here. So as you can see, so this catheter actually goes into the anterior epidural space, and we mechanically, uh, uh, do an injection, and we actually lyse the fibrosed epidural, space here. And after the, injection, as you can see, after the, this procedure, you can see the dye spread towards the right side also. So this is called as percutaneous epidural adhesive lysis. So lysing the epidural fibrosis here. Another neglected cause, especially in women, is the SI joint pain. So usually we do this. We can do a steroid injection uh, or PRP injection into the joint here. So this is the sacrum, and this is the ilium here. So this is the SI sacroiliac joint. And again, we confirm with the fluoroscopy here. So this is the dye spread again, both the anterior and posterior joint lines are seen. So this is also one of the most common cause, and most of the times MRI is normal, and the patient still has low back pain. And so women more commonly develop it because during the pregnancy and childbirth, there is distension of distension of the pelvis. So there is stretch of the ligaments. The sacroiliac joint ligaments are stretched. So even the hormones released during the pregnancy, the relaxin hormone, so they relax the sacroiliac joint ligaments here. And if the patient, uh, if the patient doesn't exercise properly, or do pelvic strengthening or low back strengthening during or after the pregnancy, this pain actually remains. And most of the times we attribute this pain to the spinal anesthesia, which was given during the surgery, cesarean section. So this is a case of multiple myeloma with L1 vertebral fracture, as you can see. And here we did vertebroplasty. So we injected the cement through the pedicle here, and you can see the post procedure X-ray. So this is one procedure which gives immense and immediate pain relief, especially in the uh, vertebral fractures, when there is uh, fractures which is not causing the retropulsion, or it is not disturbing the epidural space. So only those conditions we do the vertebroplasty or cementoplasty. This is the video of that. So we are entering through the pedicle. You can see this is the rounded pedicle, and we are entering into the vertebral body now. So usually we go almost around 2/3 anteriorly to the vertebral body. And so this is the fractured part. You could have seen that. And then we inject the cement, which is mixed with the contrast, and we make sure that the dye or the contrast or the cement doesn't leak into the epidural space here. So once the dye starts to spread to this area, we stop the cementing here as well. So this you can see. So this is the contrast injection or the cement injection, and that is the filling happening. So the other conditions like knee osteoarthritis, we do PRP injections or viscosupplementation and help in the healing and regeneration. And we also do for advanced cases of arthritis or patients who don't want surgery for knee replacement. We do RF ablation of the nerves or genicular nerves and target these nerves to block the pain signals. From pain signals transmission is stopped here. So this is a case of patellar tendinosis again. So you can see the dark signals here with hypervascular signals here. That means there is a tear and there is a lot of inflammation around here. So again, this is exactly why we use ultrasound, because we exactly identify the area of site of pathology and inject the PRP around here. So you can see the PRP has gone towards into the tear as well. So foot and ankle pain. So mostly we see peripheral vascular disease. So this is a case of peripheral vascular disease. It's a common circulatory problem where narrowed arteries reduce the blood flow to the limbs and they cause pain, cramps, and a lot of other symptoms. And when conservative treatment fails to provide relief, lumbar sympathectomy may be considered to alleviate the symptoms and improve the quality of life. So the lumbar sympathetic chain, if you see here, this is composed of the ganglia, and which are interconnecting fibers that are the part of the sympathetic nervous system. So they lie anterolaterally to the L2, L3, and L4 vertebra, right? So this is the procedure basically. So we just go, we have now oblique the C-arm, and we see a Scotty dog, pattern here, and then we put the needle just anterolateral border here, okay, and after that we inject the dye. So depending on which side is involved, and we do the procedure. Mostly if you are doing alcohol neurolysis, maybe we are doing at one or two levels, so maybe L2 or L3 or L3 or L4, and we see the dye spread along. So this is the spread, dye spread in the lateral, and this is the dye spread in the AP view. So we can see it is close to the anterolateral border of the vertebra. Okay. So again, coming to the cancer pain, we do sympathetic blocks like we discussed. And so this was a case of Pancoast tumor here, which was causing impingement on a lot of nerve structures here, causing upper limb pain to the patient, severe neck pain and upper limb pain. And so we did a stellate ganglion block here. So stellate ganglion block. So basically the stellate ganglion, or here we specifically call it as cervical sympathetic chain block. So it just lies on the longus colli muscle here and in between the longus colli muscle and the prevertebral fascia. This is the prevertebral fascia, and we pierce the prevertebral fascia and then we inject. Otherwise, if you are giving on top of the prevertebral fascia here, the drug might spread, medially or laterally, and there can be a lot of hoarseness of voice and other side effects of the injection. So make sure you, when you're doing the stellate ganglion block, you actually pierce the fascia here like this, and then you inject the medication. And we can confirm this with the giving the dye again, and you can see the stellate ganglion which lies anteriorly to C7 and T1 vertebral body here. So this also gives good relief immediately to the patient. So finally, the pain management specialist plays important role in coordinating additional care such as physical therapy, psychological therapy, and rehab uh, programs in order to offer patients comprehensive treatment plan with a multidisciplinary approach to their pain. So multidisciplinary approach is very important, taking help of the physiotherapist, physical therapist, psychologist, who can do cognitive behavioral therapy, CBT treatments. So together, the multidisciplinary approach is what is recommended and gives good, effective, helps in effective pain management. Thank you. Any,
Thank you, Dr.
Thank you, sir. Thank you.
Ah, yeah. Shall I talk?
Yeah, sir. Sure, sir.
Yeah, because Dr. Tushar was our alumni student here, and I am very proud of him. Department is proud of him, and
Thank
he's
you.
he was, when I was giving some blogs, he used to take a lot of interest and prepare everything, and used to be sincere in that, and worked hard in our department. And then after this going from here, he started along with Vikar, Dr. Vikar, another student, pain clinic in Bangalore set up. I visited his setup there, and wonderful setup, very meticulously planned. And he has taken a pain career, but I was never imagined that Tushar will take pain as a career, total career, and completely concentrating on that. And because when I was managing since 85, I was involved in pain management. Before that, I was in Tata Memorial, and I used to see some blogs and all that. But now there is a lot of advancement in pain area. And I started while giving, I remember while giving this trigeminal block. So I used to keep one skull by the side, and that will help me as a 3D navigation to read that foramen, the trigeminal foramen, and dramatic effect it used to give. Just give one Marcaine, that time Marcaine was there, Sensarcaine. And once we had patient convulsions also, our senior was giving, and they gave a little more. And remember all these things. Then C-arm came, started using C-arm. Then I used to work in cath lab. Then I started using this radio opaque dye to localize this area where to give blocks and all that. So I sort of jack of all trades. Pain, okay. Cardiac, work in cardiac. Neuro, work in neuro. So sort of jack, but now our students and recently, these people are focusing on particular area. So that gives them a very lot of depth, in their profession and in their management. And that Dr. Tushar is doing. So he has come a long way. And I hope, I'm sure in his journey, I wish him a lot of success to becoming one of the prominent personalities in India in pain management. And surely he is an inspiration for our students. So thank you, Dr. Tushar,
Thank you so much for your kind
for the
words, sir.
wonderful
Thank you.
talk. Your
Thank you, sir.
experience is talking. See how you have prepared video lecture and your procedures, and you have shown by your experience. It's just not a theoretical talk or anything. You are doing
Yes.
a lot of work, and you are showing it in the form of videos and all that. So very nice indeed. All the best.
Thank you, sir. Thank you so much, sir.
So, so pain specialist and anesthesiologists are everywhere. But what is the percentage? Many of the conditions you told are surgical conditions. It requires surgeries. How can we avoid the surgeries?
So most of the times, so nowadays that we have a little advanced technologies and advanced modalities in pain management, that most of the surgeries can be avoided. Most of the surgeries which are not progressed or not advanced, we can actually treat them with non-surgical treatment modalities. And most of the times, so we commonly see this patients who are having shoulder injuries or shoulder rotator cuff or meniscus tears. So they used to undergo surgeries, but nowadays we are able to locate the pathologies exactly where the pathology is there, and we are able to do the injections exactly at that site of pathology. So it has become site specific, and that's why the effectiveness of the treatment has increased. So there is more nowadays more approach is towards the non-surgical treatment aspects of the patients also prefer mostly non-surgical treatment aspects. But it's not like that that we should completely avoid surgery. There are obviously indications where the patient need to undergo surgery, and that is a time where we also refer to the orthopedic surgeons or neurosurgeons to do the required intervention or surgery. So we have to basically pain management is about selecting the right indication and right patient to have effective pain management.
That's great. Uh, what are the ways to avoid the sensitization?
Uh, so preemptive analgesia is one thing. So we should be able to do a proper preemptive analgesia during, which starts actually before the surgery itself, and during the surgery, proper pain management has to be done. Post-op, pain management has to be done properly, so that the patient doesn't have any kind of moderate to severe pain, and that will reduce the sensitization or acute pain going on to become a chronic pain. So this sensitization can be reduced well in advance, and there are a lot of evidence of preemptive analgesia for prevention of chronic pain. So most of the
Yes.
patients we can start on gabapentin or pregabalin. So the orthopedic patients, so usually we start with the preemptive analgesia, and then we continue for few months of their disease course.
Okay, good. Phantom limb pain, as per my knowledge, is most of the time it is acute.
Yeah.
But did you see any time that is it can be a chronic one?
Yeah. So phantom limb pain, yeah, it is mostly a chronic pain, and interventional pain management wise, sometimes the lumbar sympathectomy helps, sometimes the spinal cord stimulator helps. But we have seen some cases. I have not done spinal cord stimulator, but uh, we know from our seniors and professors that sometimes even spinal cord stimulator doesn't help. So what helps to these patients is the cognitive behavioral therapy or CBT therapy, which is very essential part of the treatment modality, especially for the phantom limb pain, where the conservative treatment like medications, interventions have not worked. So that time we need to go for we actually combine this. So basically that is a multidisciplinary approach. So they do mirror therapy for those kind of patients. But intervention wise, yeah, lumbar sympathectomy and is usually tried. And one of the main differential diagnosis for phantom limb pain is sciatic nerve neuroma. When there is amputation, the nerve end actually becomes a thicken, because there is because nerve also regenerates. There is no space for it to grow now.
Yeah.
So that becomes a
Yeah.
neuroma. So one of the differential diagnosis for phantom limb pain is neuroma. So first patient will have phantom limb pain that actually becomes converts into neuroma, and that will have post amputation pain syndrome for that patient. But yeah, I mean, it is a multidisciplinary approach. It's a very stubborn pain to manage, but yeah, multidisciplinary approach is the way to go.
Is there any role of ketamine?
Yes.
For
So
this phantom
we
limb
are,
pain?
yes, sir. We are very good question, sir. Like we are doing ketamine IV infusions nowadays, and so basically ketamine is given so in subanesthetic doses. So we use around 0.1 mg per kg of ketamine for the so basically we do this once a week or once in 15 days. So this IV infusion therapy of ketamine, for chronic neuropathic pain, including the phantom limb pain. So even the post-amputation pain, patients with severe diabetic neuropathy or peripheral neuropathy. So we do ketamine IV infusion therapy as well as Loxicard, which is preservative-free lignocaine. So we use Loxicard infusion therapy as well to manage this chronic pain.
Yeah, that's good. In between, you were talking about degenerative therapy.
Yes, sir.
Something. What are the indications for degenerative therapy?
So regenerative therapy includes any kind of ligament tear, muscle tear. So all this has to be partial tear. We cannot, correct the full thickness tear which is there. So that has to be corrected surgically only. So when there is partial tear, partial ligament injury, partial ACL tear, partial supraspinatus tears, or any kind of joint arthritis, early stages of arthritis. So basically grade 1, grade 2, and grade 3 stages of arthritis, be it the knee arthritis, shoulder arthritis, hip arthritis, or any kind of arthritis. We do PRP injections, and it has a lot of good evidence about using this treatment modalities, specifically the PRP for these degenerative conditions. So whenever there is wear and tear, so we are injecting platelets. So platelets basically has a lot of growth factors or healing factors. So vascular endothelial growth factor, epithelial growth factor. So all these factors, one thing is they actually promote healing, and secondly, they also reduce the inflammation which is caused by the degenerative conditions. So yeah, a lot of you know good evidence is also there now, like studies showing good results with the PRP injections. But again, case selection is very important. So it will not be helpful in advanced cases of arthritis or degenerative conditions.
Yes. Yeah. Does anyone having any question? Our PGs, please ask any question if there. Aditya, any
I
question?
see there is a question in chat box. My friend Gansham has asked speedy
Hello.
bullet and ganglion block with the help of earbuds and local anesthesia for
Kante
PDBH.
madam is, I think,
No,
asking
let
something.
them say. Anybody wants to say? I just want you to say, Tushar, excellent presentation. I
Thank you, ma'am.
listened to throughout to you. Excellent.
Thank you,
And
ma'am.
we are really, as sir said, we are proud to see that our students are doing excellent in a specialized branch. All the best for your
Thank you, ma'am.
for the future and for your practice. I hope one day, anyway, you are coming for the conference. We will
Yeah,
keep
ma'am,
a
sure.
workshop also.
Yeah. Sure,
With
ma'am.
sir's permission, in future, I would like to keep a workshop also where you can come and also demonstrate few blocks
Sure,
under
ma'am.
CAM or USG. Okay. All the
Sure, ma'am.
best. Excellent presentation.
Thank you, ma'am.
Thank you very much.
Sir, can I ask you a question? Yeah.
Yes, ma'am.
I'm a case of rheumatoid arthritis plus recently I went to age of 68. I'm
Yes, ma'am.
anesthesiological profession, working as a full-timer. So
Yes,
last
ma'am.
year it happened like I'm on the regular treatment of RA with lepronomide and ibuprofen and all those, and regular follow-up with the rheumatologist. But that it
Okay, ma'am.
happened like there was inevitable pain which disturbed my sleep. In spite of all that, you said the pre-gabalin and gabalin. So I had to undergo take care of one leg. But then I thought that other leg was normal. But now it started paining on the other side. Like, should I have to go for the pain management as a PRP and Gemipran of the, or I should go for the take care for the another leg? What will you suggest to me?
So
All
again, ma'am,
other RA factors are normal.
normal. Yeah.
Like,
So it's most. Yes, ma'am. So mostly
Yes.
it is age-related osteoarthritis, may not be related to rheumatoid arthritis of the joint. So it might be just age-related osteoarthritis. So again, depending on the stage of arthritis. So if there is no bone on bone, so if the tibia and femur are not touching each other, or there are not many osteophytes, so that is basically the grade 1 and grade 2 and grade 3. So those conditions, PRP is advisable. And even, so again, PRP is also, a very, uh, I can say a lot of people are doing in a different ways, but we follow certain protocol. Like, we actually give 10 billion platelet counts in one single, injection of PRP to the joint. So that is very important, because since knee joint is a bigger joint, we need a lot of good, a lot number of concentrated platelets, and it is working very good for us. So it reduces the inflammation as well, and probably it will not completely halt your arthritis, but it is going to control the progression of arthritis. So it is going to slow the natural wear and tear of the joints. So definitely, I think if you
It
can
is
take
a
a X-ray.
foolproof treatment. Like I will have the pain relief, but the pathology will go on, isn't it? What you feel?
Yes,
Then
yes.
all
So
other time, yeah.
yeah, so the disease progression is kind of slowed down. So we cannot cure any kind of degenerative process, because the wear and tear is a continuous process. It's going to happen, even if you're doing PRP, it is going to help you for a year or 2 years. If you're doing good exercises and following good rehab protocol. So that is going to keep your, arthritis in progression. That's going to halt your progression and slow down your progression for certain years.
And what about Synvisc? Like I had taken Synvisc at my partial medial meniscus repair. So
Yeah.
along with PRP, this is going to help me.
So PRP, so Synvisc is nothing but viscosupplementation, hyaluronic acid injection we give in. So that is also an anti-inflammatory, and it lubricates the joint. So whenever there is arthritis, the synovial fluid is become less viscous. It's kind of water. The viscosity is lost, and that's why the lubrication of the joint is not proper. So in that case, if there is no effusion, in that case, definitely we can give viscosupplementation injection in addition to PRP. So we usually don't combine it together. We don't combine PRP together with viscosupplementation and give. We do it on separate occasions. So we do PRP injection, and then after a period of 4 weeks, we do the viscosupplementation. Again, everything depends on
For
the
all
stage of
this procedure,
arthritis.
MRI is mandatory. For all this procedure, previous MRI is mandatory. You feel?
Uh, yeah, mostly
Diagnosis.
mandatory. Mostly mandatory, because we need to rule out a lot of other things. And since all this PRP and viscosupplementation are kind of expensive procedures, so we don't want, doing interventions and there is no result. So we don't want that. So it's very ideal to do an MRI, depending on the chronicity and severity of the pain.
So none of my family members having RS. So is it because of my profession, long standing? Like I'm working for last 42 years. Is it related to my profession, or just an age factor, or disease?
Yeah. It's not familial. I mean, see, osteoarthritis. If again, if our muscles are not stronger, if our quadriceps, hamstrings are not stronger, most of our body weight is falls on the knee joint. So then there is rapid wear and tear of the knee joint. So it's probably because of a lot of factors, a lot of other factors also. It's not because of just running around, standing, and all. A lot of various other factors together, they contribute to this arthritis. So if you're rheumatoid
Type of exercise, quadriceps fitness, and all
yeah,
this.
quadriceps strengthening, hamstring strengthening, and vastus medialis muscle, adductors strengthening. So that is very important. So that probably relieves your pressure on the knee joint as well when your muscles are strengthened.
Okay. Thank you, sir.
Thank you, ma'am. Thank you.
Hello.
Yes, Checker, please come on.
To ask one question. How do you prefer hydrodissection over corticosteroid injection?
Yeah. So steroid is just going to mask the pain. It's not going to heal it. So it might work wonders for some patients, definitely yes, but again, most of the patients, if you see with carpal tunnel syndrome or any nerve entrapments, they will be diabetic. First of all, their sugars will be poorly controlled. So in those cases, if you are giving steroid, again, that is going to interfere with their comorbidities. So diabetes, again, the sugars are going to shoot up. So, and there are a lot of other side effects of steroids as well. So it's going to cause the weakness and atrophy of the muscles or wherever you inject. So compared to steroids, now there's a lot of good evidence of hydrodissection using dextrose, just normal, whatever, like, we get 25%, 25D. So we dilute that 25D to 5%, and we inject it around the nerve in the carpal tunnel. So wherever there is nerve entrapment for carpal tunnel or myalgia parasitica, LFCN nerve, so we do hydrodissection around the nerve. So,
Okay.
so that is going to relieve the pressure on the nerve, one thing. And the dextrose, I think I discussed, like, it blocks the TRPV receptors. So basically, that's the capsaicin receptors. So once that is blocked, automatically there is, relief in pain. But like I told you, like, depending on the severity and chronicity, we need to repeat these sessions. So since we are using
Okay.
dextrose, it's like, very safe, and we can do n number of times also. If it's a severe carpal tunnel syndrome, then the surgery is only the option.
Okay.
Tushar,
Yes,
Basically
sir.
for carpal tunnel you are using it.
Yes, sir.
Can I ask one more
Dr.
question?
Tushar.
Yeah.
Yes, sir.
Yeah.
Sir, we give, as an anesthesiologist, we give lots of peripheral nerve blocks for all procedures of upper limb, lower limb. It has been said that we always add dexamethasone, 8 milligrams or 4 milligrams. But if this, I have just read it by Hadzik that dexamethasone is a neurotoxic. So why not give intravenous instead of perineural? Is it so?
Instead of dexamethasone,
You can give intravenous. Instead of
Ketamine.
it has got the same effect. Dexamethasone. Intravenous instead of
Okay.
perineural.
Okay.
Is the dexamethasone neurotoxic? That's what I want to know.
It's not neurotoxic. It's just going to prolong the effect of the nerve block. One thing. It is myotoxic basically. So when you're doing injections around the nerve, if you're accidentally giving the injection into the muscle, it is myotoxic. But again, only repeated injections is going to cause that. A single dose, I don't think that should be a problem.
It said that intravenous dexamethasone has got the similar effect like a perineural. So why not give intravenous, which is at the
Yeah.
easiest
So yeah, I don't practice anesthesia anymore, like regional anesthesia anymore. So, and most of the times we do give perineural dexamethasone only, just to, since it's localized, so it doesn't have, so if you're giving IV, there is going to be systemic effects of it. So it's going to go to every part of the body. So, that depends on the patient selection. Again, the young patient shouldn't be a problem. But if you're giving dexamethasone probably to a, elderly patient with comorbidities, then again, there is going to be systemic side effects of corticosteroids. So, but again, 4 mg or 8 mg, I think single dose shouldn't be a problem.
That may
Tushar,
be for
Dr.
the
Tushar.
duration.
Yes, sir.
Okay.
Yes, sir.
Shall I say something?
Yes, sir. Sure, sir.
See, instead of
Yes.
dextrose, inward sugar is there, no? Some inert sugar. What is that? That we use. Can it be tried? Probably you can try it.
Okay, sir.
Give it a try.
I think,
In diabetes or anything, where dextrose, instead of dextrose,
yeah.
inward sugars are there, no?
Yes, sir.
That
For
can it be tried?
hydrodissections.
Because same receptors it may act, no? You told us some receptors it act.
Yeah, TRPV receptors. Yeah. So I think,
Ah.
yeah, sir. I think, yeah, that should
Inert
be
sugar, especially in
yeah.
diabetic patients.
Yeah.
Isn't it? Just
So
my
yeah,
thought.
yeah, sir.
Just my
Correct.
wild thought. Nothing.
Correct. So it's a very Correct, sir. It's a very valid thought, sir. But we usually use around 10 ml dextrose around the nerve. So usually that shouldn't be a problem even in cases of diabetic patients who are even uncontrolled sugars also, because that's going to be very localized. So that's going to stay in the fascia itself. So most probably it will not cause increase in sugar levels as such. But yeah, I think that should be something which can be tried. Yes, sir.
And I used to give streptomycin
Yes, sir.
sometimes
We used to give,
because
sir, I
it is
think
a
lumbar
intracellular.
sympathectomy. We used to do, sir. We used to use gentam. I mean, I think
Because what I
gentamicin.
read in Scientific American that time, nobody had
Yes,
done
sir.
that. It was a neurotoxin, intracellular
It is a
neurotoxin.
neurotoxin. Yes, sir.
So
Yes,
I
sir.
tried, but such substances which are intracellular neurotoxic, you said botulinum toxin, like
Yes, sir.
that, so many other things may be there, which
Yes, sir.
are long acting, but they don't destroy the nerves.
Yes, sir. Sir, phenol is one thing. Phenol is
And
one
it
thing
can
we
be
can use.
investigated.
Yes, sir.
But
Phenol we
here
can
now,
use. Phenol
yeah,
crystals are available, so we can dilute them and make it as around 6% concentration, 6 to 8%. So
yeah.
that can be used. It is a little less destructive than alcohol. So
Yes.
phenol is one option, but it
Because
is not
alcohol
easy.
and all are destructive, not totally.
Yes, sir.
I thought like
Destructive.
that and used, but I don't know. They have not done proper studies
Yes,
on
sir.
that.
Yes, sir. Yes, sir. So I think Vasudha ma'am is asking if you can use NS normal saline instead of dextrose. So basically, yes, we can definitely use normal saline, but it is why dextrose is two reasons. One thing is hydrodissection of the nerve. So that's going to relieve the pressure and increase the blood supply to the nerve, and the ischemia or the edema of the nerve is reduced. The other thing of dextrose is in the nerve entrapments. Studies have shown that there is glycopenic environment around the peripheral nerves, and even the dextrose, blocks these capsaicin receptors. So that is why dextrose is preferred than normal saline.
Yes, in many cases, in fact, I have, in case of diabetics, no, for hydrodissection or hydrodilatation of shoulder, I have used normal saline instead of dextrose.
Oh,
So the
shoulder.
results are
Yeah,
equally
yes,
good.
ma'am. Hydrodistension of the joint. Yes, ma'am. We use normal
Yeah.
saline only. Yes.
Yes.
I think there's another question of using a spinopalatine ganglion block with the help of earbuds and local anesthetic for postural puncture headache. So definitely this is a very good, non-invasive option, and you can do it immediately for postural puncture headache. So we just insert the, cannula or the, so there is also, I think, pap smear buds also, I think we can use it nasally, and we just put intranasally both the sides, and Loxicard around 2%, we inject it through the catheter. I think that also is an good option to consider before going for little invasive procedure like epidural blood patch. So even now studies are coming up that greater occipital nerve block also uh, gives pain relief for postural puncture headache.
Okay.
So anyway, any more questions?
Sir,
So I
one
think
question, sir, one question, like all these procedures you said they are costly. So are they covered under insurance?
Yes, RF ablation, neurolysis procedures, cancer pain procedures, most of these procedures are covered under insurance. But the procedures like platelet-rich plasma, bone marrow injections, bone marrow aspiration injections, or regenerative therapy in general, they are not covered. So this is not an approved treatment as such. So these treatments are daycare also. So regenerative treatments are mostly not covered, but other treatments like transforaminal epidural injection or RF ablations and neurolysis are covered under insurance.
Any more questions? Shall I go for vote of thanks?
Yes, sir, please.
Yes. I, Dr. Patil Jaiwan, on behalf of Karad Society of Anesthesia, would like to congratulate you all first to be a part of this amazing webinar on the topic chronic pain management. For on the topic that we have witnessed today evening, which was really useful for all. To begin with, I would like to extend my gratitude towards our most valuable, honorable webinar speaker, Dr. Tushar. We are very much grateful for your nice presentation and enlightening us with your knowledge on the topic, and
Thank
for
you.
highlighting basics and updating with the most modern knowledge. I would like to thank Dr. Dhulkar sir for all his efforts and time you have taken in for your thoughts and information about the chronic pain management and its evaluation of pain management. Furthermore, I also indebted for uh, treasurer of Society of Anesthesiology, Maharashtra State, Vikas Karne sir. He was present for the webinar. I am happy to thank Zamali sir. I think he's not here, but I want to extend my thanks to Zamali sir for his kind support. A big thank you to Dr. Aditya Khoth for his sincere efforts to make this academic feast a grand success. I also would like to express my gratitude towards all the participants of the session. Thank you, Genica Technology Support Team Ganesh and Abhijit for their untiring efforts till the last moment. Wish you all good health and long live ISA and KSA.
Thank you, sir.
Thank you, Tushar. Thank you,
Thank
sir.
you. Thank you so
Thank
much,
you
sir.
all.
Thank you, Dhulkar sir. Thank you all.
See you soon
Right.
in
See you
conference.
soon. Yes, sir, definitely.
Are you going to have YouTube link for this?
It's already there. It's already there.
It's already there.
Thank you, everyone.
Okay.